continuity of the occlusal plane, 90% of the single tooth are cemented on implants, like we do on prosthodontic on teeth. When I removed after 1 year, you can perfectly see the connective tissue and the epithelium, very healthy. This little blink of blood is because I touched with the coulisse. It's my fault. But everything is doing very well. And you can see that mature tissue has a stable shape. It seems like sharp. I thought this can last forever. It was 1 year. But first thing, the papilla switch. So I had almost a full papilla in the front and no papilla in the distal area. And they changed the position. So at the end I had the full papilla in the distal and I totally lost the papilla in the medial. I could have predicted this because here I have more than 5 millimeters. The CAJ is here, cement enamel junction, CAJ. Is very far away for the first bone peak. But the other side is 5 millimeters, so I can have the papilla. Second problem, are we reducing the chance of a recession? 1 year? 2 year? 3 year? 4 year? Why did I have a recession? So I want you to understand through images why I had a recession. Perhaps because the width of the tissue was not enough. Perhaps the emergence profile was wrong. Perhaps the implant positioning was wrong. I don't know. We have to find out. You will always see in my single crowns a palatal notch. This is just next to the surface of the tissue, so it's cleanable. And it's made in order to remove the crown. Very comfortable. Because if you take a clunch, you can chip the ceramic. You can ruin the ceramic. These are all cases where I had the opposite situation. Creeping, 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 creeping. Tissue going on the top of the crown. I want to understand how to use this power to fix my difficult situations. To do this, we need parameters. Because on Monday morning, if you have parameters, you understand where those tissue will be after 5 years. So let's begin with our course. There's an article from Professor Cordaro who says when you are in a aesthetic risk area, you should always insert an adjunctive tissue graft. First time I read this paper, I didn't understand. Why soft grease tissue graft is so important. So we did an experimentation. This is an expective cohort study we did at the University of Milan on 530 implants examined. The average follow-up is 5 years, up to 10, and the baseline is the final prosthodontics. we could define with how statistical significant the more keratinized mucosa we have around an implant, the more papilla we will have. And the more keratinized mucosa buccal to the implant we have, the less periimplantitis we have, less problems. And the patient, of course, was evaluating, personally, highly aesthetic. We need keratinized mucosa in order to have more papilla and more resistance to periimplantitis. So it's our duty never to leave a situation like this. It's our responsibility to fix the quantity of keratinized mucosa around an implant. It takes minutes. But this changes the outcome in the long term of this implant. It's easier to clean. I don't ask for pain to my patient if I perform this. It's in the box. If I place the implant, it's my responsibility to place the tissue. Sometimes it's more demanding. Here I have a very narrow crest. This is narrow with wide base. So I will do a hybrid split crest plus bone regeneration. The cortical is very thick, so the elasticity is not enough to open it, and I have to make these holes to increase the elasticity. Otherwise there is too much pressure, and if you compress too much the bone during the split crest, it will resorb. Is it okay with the translator? Is it okay with the timing? Thank you. So I will addict also an augmentation with a percentage of autogenous bone and some bovine bone, a resorbable membrane. This is a suture to keep the membrane stable during the suturing on top. So how do you do this? You do the release incision, and you will suture from the inside of the lingual to the bottom of the periosteum under the releasing incision, and then come back. You will see this later. Then you close primary enclosure, horizontal mattress, interval with single stitches in the middle. This is the standard suturing from Massimo Simeon and Sasha Jovanovic for any bone regeneration procedure. This is the implant positioning. And when we are ready to use the implant, we have zero amount of keratinized mucosa. This is 1.5 millimeters. I cannot use it, it's not enough. So in this case I will do something quite strange, because I like strange things, but you should always stay open-minded and stay out of the box. So first incision is on the top of the surface of the periosteum, half thickness, and I remove the mobile epithelium. The second incision is full thickness. This is the amount of bone. I have bone on top of the implants, even too much, so I have to remove some. These are the implants. I will put some wide screws at the beginning, even wider than what I need, because after, when I go back to the normal size, I will obtain more tissue width. It's just for a maturation of 2 weeks. Then I will change. And I will suture the deep part of the mouth, the fornix, of the mobile mucosa. This is suturing the buccinator. The muscle buccinator is sutured down. This is the paper from the suture box, sterile. I use it to make the measurements. Then I can go to the palate, and I will take the surface. We will speak a lot about soft tissue this morning. Minimum distance 1.5 millimeter from natural tooth, always. Never go in the soft palate. This is avoided. Very risky. No soft, only keratinized mucosa. I take only the surface of the palate. Here there is the great artery of the palate, but it's not a problem for me because it's deep. I'm taking the surface. This is the graft. Here is whatever you like. Somebody put a sterile glove. Radoslav Jadach from Poland has been publishing a lot on sterile gloves to protect this. What I like to do is to put some fibrin mat on top, and to protect with the periodontal cement. If you avoid the contact from the tongue to the connective tissue, the patient will not feel a lot of pain. You will reduce the discomfort of the patient. And then you have to suture in a very stable way the graft. I can do this kind of graft here because it's not an aesthetic area. You cannot do this in aesthetic area because the color of this graft is different from the original. In aesthetic area you have to think different. But I can do this because it's hidden, nobody sees. The purpose is to be able to clean the tissue and protect the implants. You might think that this tissue is too big. But remember that after maturation, in the lower part of the mandible, it shrinks by 50%. It's very normal. So this is the healing after 1 week, because I was quite in the surface. And you see it shrinks by 50% because the muscle tend to go back. And now you can see the volume. 2 weeks has passed. So I can remove the sutures and I can go back to the original correct healing screw diameter. Now I'm ready to take an impression for the provisional. This is after probably 1 year. I would like to introduce you this. It's called the phenotype modulation. It's nothing new. But it's a new point of view, a new philosophy of using tissue around implants that I would like to share with you. When you harvest soft tissue in the mouth, you have multiple choice. One of these is the surface of the mouth. The surface of the palate is very safe because the artery is deep and you only take the surface, 1.5 millimeter maximum depth. You don't need more. You should never take the wrinkle area in the frontal part of the palate, otherwise the wrinkle will be kept. The color is very white, so you cannot use this in frontal area on the surface. What you harvest is a very dense connective part with a lot of collagen type 1 representation. It's thick and hard and easy to suture. The epithelium you can keep or you can remove. If you put inside the tissue, you always have to remove the epithelium. You can remove before harvesting with the diamond bore, or after, being very careful. You will see these techniques. So this is an example on how you can use this tissue. It's suggested to suture with very little sutures, monofilament. Monofilament reduces the plaque accumulation. And you have to do many suture, no tight. If you tighten the suture, you will reduce the perfusion of new blood to this tissue. Free graft has to receive new blood supply from around. So you have not to tighten much. And it has not to move, has to stay immobile. Let's see a case like this one. This is a thin biotype, and I suppose that there is a root fracture at this premolar. The patient feels a very high pain if I touch it. And when I probe, it probes 2, 2, 10, 2, 2, 10. No mobility. Radiographic is perfect. This is the removal. Here is very thin. But the buccal bone is intact, is present. If you have bone, you can place implant here. So I take a little part of the palate, 20% bigger, because after removing, it dehydrates, reducing the size. So remember, 20% bigger is the minimum. Because after removing, reduces hydration and shrinks by 20% minimum. 1.5 millimeter, 1 millimeter. The more you can take, the better it is. Put the implant, put the graft. This suture is too tight. It's my mistake. This was granulation tissue. And after removing, you can see what is here. A vertical fracture. Very difficult to diagnose, because radiograph is perfect in the first 24 hours, of course. This is just some fibrin to protect the palate. I put under dam, and I use the same crown of the patient. This is the gold ceramic crown that she has before. I cut away the root, and I use the fiber reinforced composite to splint as a Maryland bridge. But you have to do this under the dam, because you cannot use the composites on top of a graft. Even the relining and the turbine you have to use with the mounted dam on top, silicone dam. The patient goes away like this. This is the tooth, out of function, so the aesthetic is respected. 6 months later, a little C incision from the palate, I push buccal. This is the healing of the palate. I had a little bit of remodeling. This is normal. That's why you always have to put the implant palatal. Always. Remember that in the upper jaw the forces of occlusion is in this position. So the ideal hole of the passing screw is in this position. So the forces go straight on an implant. You will see later on the biomechanics of implants, how it affects the forces. And managing the emergence profile, you see how much tissue we have. I was lucky I can also sell one more crown to my patient. So this is 2.5 follow-up. With very little, we could have a creeping. It's just an exercise. We didn't need there. These are very old implants. Now I use something better. Another grafting you can use is the deep part of the palate. This is very common all around the world. Now this trend is changing because you are limited in harvesting from the first premolar to the first molar. Because this is deep, you have a lot of problem of bleeding for the great artery. So never stay out from this square. If you go on the back, you can have problem of bleeding. If you have a bleeding problem, you can go down with a suture and tight close it. Full thickness suture and close it very tight. it's more difficult to harvest. If you make too thin the pedicle flap, it will die. What you obtain is a very poor connective tissue. It means that the consistency is very little. Collagen type 1 fibers are very little amount. And you have periosteum, fat, and glandular system. And if you break your arm and you keep it still for 40 days, your arm will become very little. Did you catch it? If you don't use a part of your body, it will reduce the volume. Shape and function in the body, they're connected. So this fat, the periosteum and the glandular system, when you put somewhere else, they lose their function. The fat goes away because you don't have any more mechanical activity on top. The glandular system goes away because there's no more ductum. And the periosteum goes away because probably there's no bone to protect. So, what happens is the total volume of this will reduce a lot. After maturation, this becomes less 50%. So when you harvest it, you have to overcorrect in quantity. This is a situation quite strange. The patient had endodontic problems, and she visited 7 different dentists to fix the problem. My endodontist treated her with a 40 pair magnification microscope. But she still had a problem. And she really insists to remove this tooth, because I don't like to remove healthy teeth. The endodontic was good at the second moment. But there was a problem with the lateral channel that we couldn't close from the inside. And doing an apicectomy would have removed too much tooth. We couldn't even see this from the radiograph, so we noticed only after removal. We placed an implant. I placed immediately the final abutment that was prepared by the technician before the surgery, and made a replica of the abutment. I placed some bovine bone as a socket preservation. We will talk about the socket preservation if we have time, and if you like. This is the harvesting from the internal part of the palate, and this is the harvesting in place. You see the yellow? That's the fat. It will disappear. First, it will be reepithelialized. Second, will be resorbed. This is the abutment that is pre-made. This is a very old case. So again, it's an implant that I'm no more using. The technique to keep the abutment immediately at the beginning of the immediate load